My name is Jeff Taylor, and I'm at the 25th CROI here in Boston with Dr. Pablo Tebas.
Hi, Jeff. How are you?
Welcome. How are you?
Fine.
So it's the last day of CROI, and there's been a lot of interesting data being presented this year on the cure, which is happening every year, and it's kind of building up momentum, and there's a lot of interesting things. So what stood out for you at the conference so far?
Well, it's becoming, 25 years is a long time, and it's becoming more mature in many ways.
Right. Well, 25 years ago, we didn't dare talk about the cure, right?
And I think, overall, the conference has been very good, as usual. I think the most interesting and the data that is going to change practice is in TB, but I didn't attend those conferences. I went mainly to the lectures surrounding the cure, strategies for the cure. And I think there has been very interesting data presented. Still, we don't have the cure, obviously. But if we think about the strategies that we are thinking that are required to eradicate infection, if we focus on the kick, trying to reactivate the virus from the latent reservoir.
So part of the kick and kill strategy.
It was a mixed bag. So there was a clinical trial looking from the ACTG, looking at 5315, a single dose of romidepsin, several doses, to see if that will activate the HIV reservoir. There was a publication from I think a Danish group that showed that you can wake up the HIV virus to start expressing proteins, even to replicate, because they were able to detect viremia. And that's required to allow the immune system to target the reservoir. So they didn't confirm that. And that was a little bit of a bummer, because we had a lot of hope in romidepsin, and I don't think it's going to be the latency reversing agent. But there was a lot of data in vitro, and the poster session was phenomenal. So there was a group looking at TLR9 as a booster of the CD8 immunity against HIV. There was a very interesting poster clinical trial, phase 1. I couldn't believe it was not an oral, from the Minnesota group looking at a superagonist of IL-15 superagonist that really seems to activate the HIV from latency. And the dose was low, but it looked safe. So, it was only 9. Team Checker.
Yeah.
Very nice data. Then there is a Chinese study looking at blocking interferon as an activator of the reservoir. We know that interferon has antiviral activity. If you block interferon, the HIV seems to activate. So there is a lot of presentations in the poster sessions that look at different ways to kick the reservoir, and I think we have several leads. There was another drug that, some of those interferon blockers are used in therapeutics, so they have been in humans. So it's not a big leap of faith that we are going to start doing trials looking at some of these latency reversing agents. That's in the kick. There was a very interesting presentation too in the kick. This is a monkey study that was done by the Harvard group here.
So Dan
Baruch, looking at TLR7 agonists. So what they did is they took 44 monkeys, they infected them acutely and treated them with antiretrovirals relatively quickly, 1 week. 44 monkeys, 4 groups. One, they did nothing. Another group, they gave a broadly neutralizing antibody called PGT121. The other group, they gave the TLR7 agonist, and the last group, they gave both. This was given when the monkeys were suppressed with antiretrovirals, and then they stopped the antiretrovirals a while after the last dose of the antibody. Some of them, the TLR7 and agonist and the antibodies were given at the same time. And half of the monkeys controlled the virus. And they tried to look for HIV, not in the way one would think, but they took cells from those monkeys and infected other monkeys, and they were unable to infect the monkeys. So it seemed that those monkeys have cleared the infection. It's very promising. The TLR7 is in humans, has been in humans, and the antibodies start becoming available. So it's a monkey study. Monkeys are not humans, but it's the first time they tilted the study towards success, because these were acutely infected monkeys, treated very, very, very early, so reservoir is small. But as Paula Cannon used to say, you only need to cure one person to prove that you can do it.
Right.
So
Timothy Ray Brown, right?
Yeah. So So I think that was very promising. So a lot of promise in this on this strategy.
So with that monkey study that Dan Baruch did they have any clue as to why half responded and half didn't?
Well, no, they are looking at explanations for that. They think there is a boosting of the CD8 responses there. They didn't present, or I didn't see a lot of that about what it was the effect on the reservoir, because I think that was the hypothesis that by giving the TLR7, the cells that are infected with HIV start expressing protein, and the antibody is eliminating them by ADCC. But I have to relook at the presentation to see if I can stop in some of the slides to look at the data that supports that there was a decrease in the size of the reservoir. But it was very interesting, and I think we will hear more in the future about that type of strategy. More things about the cure. I think the reservoir matters, and there is a presentation this morning from the CTG, also the neuro study, looking at reservoirs in the CSF and linking them to neurocognitive function. The association is not that strong, but it's an association, so we might need to start worried about the CNS reservoir, although I don't know how relevant it's going to be, but we have to look at it. We have been sort of ignoring it.
Both for the cure and for clinical reasons as well, right? It can be associated with neurocognitive
dysfunction, and then it's not easy to sample. I mean, I don't know how good a LP and a CSF is a surrogate of what's going inside the brain, the tissue, but it's not a procedure that is simple.
Well, I know there's some autopsy studies that are being done to start looking at that. UCSD is doing something called Last Gift in terminally ill patients, where they do rapid autopsies so they can get really good samples to examine
I
that.
wasn't aware of that data. Good. And what else? I mean, so that's in kicking. In targeting more boosting the immune system, not a lot of data on new vaccines against HIV or anything like that. There was some presentations about broadly neutralizing antibodies, but I think the combination of broadly neutralizing antibodies have not been presented in this meeting. I think the group of New York is looking at using combo antibodies and probably publishing it directly. I know the study is almost done. So, and this is more on a strategy for a functional cure. So it's giving the antibodies and stopping antiretroviral therapy and see if the combo of the antibodies can maintain viral suppression, which seems like is my work. So.
And then anything interesting in gene therapy?
I have not seen any clinical trials presented here about gene therapy. We are at our group in the University of Pennsylvania at Delaney. We're going to be opening a CAR T cell trial. So,
you want to explain briefly what CAR T cells are and how they work?
So the problem of vaccines with HIV is that it's a little bit of a not directed process. You don't know what is going to be when you vaccine somebody. You don't know exactly how it's going to be the immune response, but you can engineer the immune response. So what a CAR T cell is a cell that has a T cell receptor. The CAR is a chimeric antigen receptor. So what it does is it defines the specificity of the cell. So by selecting what is outside the CAR, that molecule, you say this T cell, this CD8 cell, or the CD4 cell is going to go for this specific antigen. So they are being designed to treat leukemias, for example, very successfully, and they were approved recently. 2 months ago, the FDA approved, 4 or 5 months ago, they approved the first CAR T cell therapy for leukemia. So what they did in that study was to this receptor recognized a protein that is only expressed in B cells. So they target all the leukemic cells and they eliminate them. They are incredibly efficient. So the CAR, what we want to do is to put a molecule outside that will target HIV infected cells. And we have decided to use CD4 because it has been in humans. 15 years ago, people did the study with the old generation of CAR T cells in HIV patients, and the patients 10 years later are doing fine. But now there has been
Was that the Sangamo trial you were referring to?
No. This was Carl June in 2003. CD4 is CD4 zeta.
Okay.
So they did this, and the cells have survived for more than 12 years. But now we have much better signaling inside the cell. So now we know how to make these cells proliferate, be more active, survive. So we're designing these CAR T cells, and we're going to be opening the study in the fall. But they have to be combined with a latency reversing agent. And we don't have a good latency reversing agent right now, because in order for these CAR T cells to find HIV infected cells, they have to be expressing protein.
Right.
If they are
you have to wake
latent,
them up first.
Yeah, if they are latent, they are not going to find them. So that's why it's so exciting to see all these new approaches to try to reactivate the reservoir. Because the answer is going to be a combination of 2 or 3 things to target the reservoir.
Combination therapy, just like we did for treatment, right? So.
Yeah, it's going to be different for cure, but it's different combination, but definitely is an exploding field. And I mean, it's remarkable the advances that are being done in the very basic science. And I think we will start seeing more phase 1, phase 2 studies in the near future. There were good things about antiretrovirals. I mean, bictegravir was recently approved. There were a couple of switch studies presented that bictegravir looks pretty much like dolutegravir. There is a lot of excitement in antiretroviral treatment because of the intermittent therapy with the injectables and the broadly neutralizing antibodies.
And also dual therapy, right? They're moving from 2 to 3 drugs in some.
From 2 to 3, from 3 to 2 is there is accumulating data that you can maintain suppression with 2 drugs. So the idea that you can induce with more aggressive regimen and then step down to 2 is becoming more commonplace than it used to be. We knew that you can do it with protease inhibitors and 3TC. I think now with dolutegravir 3TC, the body of evidence is there. We need to wait for some of the trials that are being done by VIF, like the Gemini and Tango, to show that that's it. And to show also that you don't pay a price by doing that, like more inflammation or more. I mean, if you're virally suppressed with 2 drugs, it makes sense that to do that.
Yeah. Viral suppression is viral suppression, right?
Viral suppression is viral suppression. I don't know how tiny changes on levels of inflammation. I don't know how clinically relevant they are, but statistically for sure. But we'll see. We'll see what happens. It will lower the cost of taking care of patients with HIV because, of course, you will go from 3 to 2 drugs, and one of them is generic. I mean, 3TC is generic right now. It will affect the care because of patients because the U.S. HIV care is so crazy. I mean, a lot of the clinics depend on 340B funding. So you have this perverse situation that if you use cheaper drugs, you get less support for your clinic.
Right.
It's completely insane, but I mean, that's the American health system for you.
Yeah.
And it's very different if you're in public insurance or you're in private insurance.
Right.
So, of course, if you're in a private insurance, the insurer would like to lower the price of the cost to make more money and to provide care for more people.
Right.
But if you're in public insurance, the cost of the drugs subsidize the care.
Exactly.
It's just a perverse system. And for foreigners, it's so difficult to understand.
It's difficult for Americans to understand it. No one.
It's very difficult to understand how it was created and why we're in the situation we are.
Well, all the more reason for a cure, right?
Well, yeah, I mean, we should cure people. There is a lot of stigma about HIV still. And for patients living with HIV, it's very important that they feel that at least there is the possibility of a cure.
Exactly.
The good news is that people are living longer, they are healthier, they are taking 1 pill a day many times. These pills are much better tolerated than the old ones. There is much less side effects. And in general, the HIV population is doing well. Yeah. At least in the developed countries, if you have access to care. If you don't have access to care, it's messy. Here,
which is true even in this country, yeah.
Yeah, everywhere it can be complicated. But I think overall, there has been a lot of improvements, and I hope in the next few years we work really on the cure and to try to eradicate HIV. the first step is going to be this therapy every 3 months or something like that. And
Yeah,
then,
it's going to be incremental.
and then it was going to be incremental, and then we will get to.
So you're thinking it's going to be a functional cure that will, over time, get better and better and last longer and longer?
Yeah, I mean, we need some fundamental advances of identifying what is the reservoir, which that was a negative, not so positive. I mean, there was a lot of excitement a few months ago about this marker for the reservoir, CD32A. Was a paper in Science, and everybody, oh, this is great. Now we know what cells to target, because now, but it turns out that 4 of the 5 different groups have proven that it's not the reservoir, or it's not what they thought it was. It's not a latent reservoir. It's probably cells that are replicated to some levels. There was also several posters about the safety of treatment interruptions, which I think they were very encouraging. When you
So in the context of a cure trial, you have to interrupt
therapy to prove that that the virus doesn't rebound. Treatment interaction trials have been a little bit disappointed because everybody rebounds, but there is no other way to test the effectiveness of an intervention. So there was questions about the safety of treatment interruptions. Of course, it's not safe proof because you're allowing the virus to come back. But there was a lot of concerns in the past about receding of the reservoir, that by stopping therapy, you're going to lose all the benefits that you had, even in acute infection. There were 4 or 5 studies, and the findings are very consistent. When you stop therapy and you become viremic for a few weeks, and you restart therapy, 6 months after you restart therapy, you're where you were 6 months before. So it tells you 2 things. One, that the reservoir is incredibly stable, which is difficult to understand why, but that's something that we need to figure out. And the other thing is that by doing these brief analytical treatment interruptions, you really don't pay a huge price on the size or the composition. There was very nice studies, Katie Barr had one, looking at changes in the reservoir. So the virus that rebounds is not enriching the reservoir. So the reservoir, when you resuppress after a treatment interruption, is not coming from the virus that went
the same
out.
reservoir that was there before.
It was the same reservoir that was before. And that is reassuring, is that we don't understand how the reservoir is completely established. Why is this constant number? Although we know that there are clones of cells that go up and down. There was a nice presentation about that over time. But it remains unbelievably stable. 1 cell per million PBMCs. And why? I mean, that's pretty amazing. That is so tiny and so fixed is something that it mesmerized me. So, I mean, it's interesting, and I think there has been advances. And next year, I think we will hear more. And hopefully we will start seeing trials with interventions that have a signal.
Well, and as you say, now we can do them safely, and patients can enter those trials knowing they won't pay a clinical cost.
Not a huge clinical cost. I mean, there's always a risk, because when you stop, there is inflammation. I'm not going to try to minimize that there is a risk. But in the setting of a well-monitored treatment interruption, I think there is a risk that for people that want to contribute to finding a cure for this terrible disease is reasonable. It's not, I have a 50% chance of something catastrophic happening to me.
Exactly.
No, it's not that. And it's a small risk, and for people, it's not for everybody, but for people that want to contribute to the cure, I think it's a reasonable risk. And I don't feel, of course, when you do these trials, you're worried as an investigator. I'm putting my patients at risk for this, and you obviously don't want to do that because you care about your patients, but the risk is reasonable.
Well, as you mentioned, I mean, in the community, there's so much desire for a cure that people are willing, just like in the early days of treatment, that people are willing to take those risks because they believe the outcome.
Yeah, the community drove the advances on antiretroviral therapy at the beginning of the epidemic, and I think the community will drive the advances for HIV cure. So we count on you guys.
And you. It's a team effort. Well, thank you so much, Dr. Tebas.
Thank you.
Appreciate it. Enjoy the rest of your conference.
Thank you.
We're at the 2018 CROI. We're here with Kim Scarsi from University of Nebraska. And you just got through a press conference, and I'm going to let you set it up because a lot of important data was presented in that panel, and we wanted to speak with you about this particular panel.
Well, thank you for your interest first. So I presented today on behalf of the AIDS Clinical Trials Group, study A5316. And for that study, we specifically were looking at the impact of certain antiretroviral therapies on hormones delivered via a vaginal ring. So we thought this was an important topic because we know family planning is an important aspect of comprehensive medical care for women living with HIV. We also know that there's drug interactions between some antiretrovirals and oral medications used for contraception, but there really was no data with the vaginal ring contraception. So I was fortunate to be able to present that work here today.
Because there's a lot of absorption that goes on there. That's why it's there.
Yep, exactly.
So it's profound. So it doesn't cut down anywhere. So how did that come out?
So you're absolutely right. So I think a lot of people think that the vaginal ring works somehow differently than oral medications, but it's actually just the way that it gets absorbed. And some would perceive that maybe it would miss some of that risk for interaction because you don't have the oral route of administration. But we did find very similar results. So we compared atazanavir, ritonavir-based antiretroviral therapy to a control group, as well as efavirenz-based antiretroviral therapy to the control group. Fortunately, the good news was the protease inhibitor-based regimen, although the estrogen was decreased a little bit, the progestin, which is what we think offers the effectiveness of the contraception, was actually a little bit higher than what we saw in the control group. On the other hand, our efavirenz antiretroviral therapy group had about an 80% reduction in the progestin exposure and about a 50% reduction in the estrogen exposure of those hormones released from the vaginal ring.
So you need to adjust the dose? And
that would be ideal if you could increase the dose. Vaginal rings are a little tricky because you'd have to adjust how much drug is released per day. So it would require a bit of a change of the formulation.
Not going to happen.
Yeah, but I think what's important, and I think hopefully how we can learn from this information, is the new vaginal rings that are under development, specifically for HIV prevention, either alone or combined with a hormonal contraceptive, can hopefully use this information to help understand how to best use that type of vaginal ring in women who maybe aren't on antiretroviral therapy like we were using, but maybe are on other medications that behave similar.
Yeah, so you really have to look, do the pharmacogenetic or dynamics of it and so forth.
Yeah.
So it's important to have this information. So where do you go next? What's your next steps?
Yeah, so we're doing a few different things. You mentioned dose adjustment, and we are, through the AIDS Clinical Trials Group, evaluating that strategy for efavirenz plus oral forms of contraception, specifically levonorgestrel, because that's a little bit easier to adjust the dose orally, and we're evaluating whether or not that would be an effective strategy to overcome the interaction. Also working with a great group of investigators from the Infectious Diseases Institute in Kampala, Uganda, and we're evaluating dose adjustment of the implant contraceptives with efavirenz, also to try to overcome that interaction. Specific to the vaginal ring, I think that I've started to talk already with people really in the field of HIV prevention and developing these products, and they've been great as far as understanding the implications of this work, and I think they'll take that into consideration as they further develop these important methods of prevention for women.
So just to backtrack a bit, the outcomes were the same oral or vaginal ring?
So
or change a little bit?
They're a little, they're in a similar direction, I guess I would say.
Okay.
So slight differences. I think probably the biggest difference is we saw actually more of an effect of efavirenz on estrogen via the vaginal ring than we had orally. And that could have implications for women who use the ring also for hormone replacement therapy. Because of that difference. So we saw a bit more of an effect there. For the other drugs, the directionality of the interaction was all the same, and some slight variations here and there, but generally speaking, we saw similar results.
So what are you're going to continue on this track, or you're making some consultations with other people, as you said, pharmacodynamics.
Yeah.
What are you going to be doing in next projects? Do you have any ideas?
Yeah, so as I mentioned, that ACTG study that we're looking at the double dose, that's actually just getting under development now, and that is actually based on new guidelines, relatively new guidelines from the UK and the EU, which actually suggest doubling the dose of emergency contraception when you use it in combination with drugs like efavirenz or rifampin. And this study is going to actually systematically evaluate standard dose versus this double dose in combination with efavirenz, and also for TB-infected patients, just rifampin containing TB therapy. So I'm excited about that because these are actually guidelines that are already out in the EU and the UK.
Right.
And I think the ACTG is poised to help inform whether or not that's actually going to work. And then more immediately, the implant dose adjustment study that I mentioned, we expect to have results for that, hoping sometime this summer. And I'm excited about that also because the main thing is women are using efavirenz all over the world. Hopefully that'll change as you roll out new antiretroviral therapy, but right now it's a really important antiretroviral.
It's a good drug, it just has
It
side
is,
effects.
yeah. I mean, we used it for so long, and you know, for women living with HIV, the challenge really is finding the right thing to use with it for contraception.
Right.
So if this implant study that we're doing in collaboration with the IDI has good results, it'll give women a real practical option for contraception until we can have different antiretroviral options throughout the world.
Well, thank you very much. I appreciate you taking the time with us.
Well, thank you for your interest.
We're always interested in the new information. Yes,
All right.
thank you.
Thank you.